provided to her earlier. Dr. Joyce Hong is our pediatric endocrinologist. She will provide further information on the case, talk about the patient progress, and discuss literature review. As for our esteemed panelist, Mr. Chia is from the Royal Hobart Hospital in Australia, and he will provide invaluable insights into the management of cases like this based on his decades of experience as a pediatric surgeon and pediatric urologist. He used to practice in both UKM Hospital as well as HKL and currently works in Australia. Finally, we will have our very own clinical child psychologist, Dr. Yang YY, who will explore and discuss regarding the psychological aspects of the case. For the audience, should you have any questions or comments, try and save them if possible to the end of the session. For the attendance, I think the link will be provided later. Without further ado, I'd like to invite Dr. Shyahlini to present the case. Shyahlini.
Good morning to all my consultants, specialists, my fellow colleagues and medical students, as well as to our honorable guest, Mr. Chia. I'm Dr. Shyahlini. I'm a pediatric master student in my final year. We'll be presenting our Grand Clinical Pathological Conference. The title of this conference is actually Who Am I? A Gender Identity and Dilemma. So I'll start off by presenting the case. Anna, who is 12 years old, presented with deepening of voice, born term with birth weight of 2.7 kilo, noted clitoromegaly at birth and was given reassurance. She was well with few brief hospitalization for respiratory illnesses from infancy to 5 years old. Prior to this, she noticed her clitoris to be enlarging and had growth of pubic hair as well, gradual deepening of her voice. In terms of family history, there's no significant family history. Her parents were non-consanguineous. She was the eldest of 4 siblings. Her younger sisters and brothers were well. Her mother had intrauterine death at 8 months of gestation. On examination, she was tall for her family, thin and had male habitus. Her voice was deep and larynx was prominent. There was no breast development. Her pubic hair was at standard stage 3 and axillary hair at standard stage 1. There was clitoromegaly of 6 cm with good amount of erectile tissue, and there were no palpable gonads and a vaginal opening was seen. In summary, Anna, a 12 years old, noted to have clitoromegaly since birth, as well as gradual deepening of voice and adrenal-K, non-consanguineous marriage with history of intrauterine death at 8 months, recurrent hospitalization for respiratory illnesses, and examination revealed tall, thin, male habitus, vaginal opening seen, but there is no palpable gonads and breast development. So I have divided my presentation into actually 2 parts, which is actually the realized female and also under-realized male. So I shall begin with my provisional diagnosis. First provisional diagnosis under disorder sex of development, DSD is at a 46XX DSD. The first one will be the enzyme. In terms of physical finding, she has a male habitus, which probably, in terms of prior staging, probably prior stage 2. She has both features. There is feature of vagina, the female extragenital genital appearance, but in terms of her phenotypically, she's actually a male. I think she's an under-realized male. So my provisional diagnosis, first one will be the enzyme deficiency under the 46X XDSD will be the non-classical congenital adrenal hyperplasia, which are the first commonly enzyme deficiency is 21 alpha hydroxylase. The point 4 is actually hyperandrogenism because she has pubic hair with deepening of voice and the signs of realization such as clitoromegaly. There's history of intrauterine death at 8 months of gestation. And point against is actually a non-consanguineous marriage because non-classical congenital adrenal hyperplasia is autosomal recessive. And there's no episode of salt losing crisis episode. I would like on further examination and also history taking, I would like on the symptoms of adrenal insufficiency, whether any symptoms of vomiting, lethargy, syncope or near syncopal or loss of consciousness. In terms of hypoglycemia, any symptoms of sweating, hunger, headache, bad temper, vomiting or loss of consciousness, and I will further ask history on realization. Any complaints of acne, dramatic change in growth, hyperpigmentation, as well as child's menstrual history. On examination point of view, I would like on the ectoperimetry measurements, the weight, the height, the BMI, the blood pressure to look for any evidence of hypertension, hydration tests where there is any poor hydration status, and skin will look for any signs of acne, hirsutism, and also hyperpigmentation. On further investigation, we would like to look at the renal profile, especially for sodium and also potassium level, hyponatremia and hyperkalemia, testosterone level, 17-OH progesterone level, cortisol, karyotyping. We'll proceed with short synectin test or look for any DHES, renin and ACTH level, left wrist X-ray to look for any advanced bone age, ultrasound and MRI pelvis to look for internal organs, especially for any ovaries or testes, as well as fluoroscopy genitogram. Next, on the sex dermal of 46XDSD, my next second differential will be adenoma or adenocortical tumor. The points for is actually hyperandrogenism. There's presence of PPK depending of voice, signs of realization such as schistomegaly, as well as the weight changes of she's being thin. On further history and examination, I would like symptoms of neurological, especially there's fatigue, weakness, headache, blurring of vision. Psychology point of view, there's any signs of depression, anxiety, irritability. Abdomen, any abdominal pain or distension, as well as symptoms of further on realization, especially acne. Dramatic change in growth, hyperpigmentation, as well as child's menstrual history. On examination, I will proceed with anthropometry to look for height, weight, BMI, blood pressure to look for any hypertension, abdomen for any abdominal mass palpable, and look for features of Cushing syndrome, especially such as central obesity, cervical fat pad, facial platoria, hirsutism, pigmented striae, and also excessive bruising. On investigation point of view, I would like to do on renal aldosterone level, cortisol, DHES, urine 17 ketosteroid, urine 17 hydroxycorticosteroid, left wrist X-ray, as well as CT MRI abdomen to look for adrenal tumor or any evidence of distal metastasis. Next, the third provisional under 46XXDSD will be androgen secreting tumors, especially ovarian tumors such as Sertoli cell, Leydig cell, and also granulosa. Points for is actually hyperandrogenism because she has evidence of pubic hair, deepening of signs of realization such as schistomegaly, and there's weight changes of being thin. On examination and history taking point of view, where there's any evidence of abdominal pain or distension, realization point of view, any complaints of acne, dramatic change in growth or hyperpigmentation, as well as child's menstrual history. On examination point, I will also proceed on anthropometry, especially the head, the weight, the height, the BMI, the blood pressure to look for any evidence of hypertension, abdominal for any abdominal mass palpable, and skin to look for any signs of acne, thinning of skin, pigmented striae, excessive bruising, cervical pad, hirsutism, acanthosis nigricans, facial platoria, as well as alopecia. On investigation point, I will look to investigate on testosterone level, DHES, urine 17 ketosteroid, FSH and LH level, tumor markers such as alpha beta protein and beta HCG, gene analysis, left wrist X-ray, and CT or MRI abdomen to look for evidence of any ectopic ACTH secretion. So next on 46XXDSD will be the exposure to exogenous androgen medication such as synthetic progestin or testosterone preparation. The points for is actually hyperandrogenism, pubic hair, deepening of voice, signs of realization such as schistomegaly. So on further history and examination, especially on symptoms of realization and complaint of acne, dramatic change in growth, hyperpigmentation, as well as child's menstrual history. And then to ask on further any usage of synthetic progesterone or testosterone, especially in the maternal or paternal site exposure. Examination point, I will ask on anthropometry, especially the weight, the height, the BMI, the blood pressure on hypertension point, abdominal and any abdominal mass palpable, skin or any acne, hirsutism or hyperpigmentation. On investigation point, we would like to ask on progesterone, testosterone, as well as DHES level. Cortisol, I will proceed also with short synectin test as well. We'll do a left wrist X-ray. Next, on 46XXDSD, my next provisional will be placenta erythematase deficiency. The points for is basically hyperandrogenism. She has evidence of pubic hair, deepening of voice, signs of realization such as schistomegaly, and there's absence of breast development. Points against is actually a non-consecutive marriage. Placenta erythematase deficiency is also autosomal recessive, and there is points against there is growth spurt of being tall. In placenta erythematase deficiency, they're usually short. On further history and examination, I would like to ask for signs of realization that complaints of acne, dramatic change in growth, and so hyperpigmentation, as well as child's menstrual history. Examination point of view, I would like to ask on anthropometry, the weight, the height, the BMI, the blood pressure, the hydration status, as well as skin to look for any acne, hirsutism, and so hyperpigmentation. On investigation, I will proceed on testosterone level, FSH and LH level, karyotyping, DHES, 17-OH progesterone level, HCG, I will proceed with HCG stimulation test, left wrist X-ray as well as ultrasound and also MRI pelvis to look for internal genitalia as well. So moving on to the second part of disorder of sex development will be the 46XY DSD will be under the category of lack of synthesis of testosterone. There will be two parts. There is testicular differentiation defects such as pure gonadal dysgenesis or absence of Leydig cell function, as well as testicular regression such as gonadotropin hormone deficiency. So my point 4 is actually for hyperandrogenism to look because the child has pubic hair. Depending on voice, signs of realization such as schistomegaly, and points against actually a non-consensual marriage. This is actually autosomal recessive. No palpable gonads. On further history and examination, look for any signs of realization, complaints of acne, dramatic change of growth, and also hyperpigmentation. For examination, look on anthropometry, especially the height, the weight, the BMI, and skin, especially the acne, hirsutism, and also hyperpigmentation. On further investigation, I would like to do a testosterone and also dihydrotestosterone ratio, karyotyping, HCG stimulation test, as well as gene analysis. Moving on under 46XY DSD, the next one is the lack of synthesis dihydrotestosterone, which is a 5-alpha reductase deficiency. For points 4 is basically the hypoandrogenism, pubic hair, depending on all signs of realization such as schistomegaly. Non-consensual marriage is actually an X-linked X-linked recessive and no palpable gonads. Further history and examination, I look for signs of realization, any complaints of acne, dramatic change in growth, and also hyperpigmentation. Examination proceed on anthropometry, the weight, the height, the BMI, and the skin to look for any acne, hirsutism, and also hyperpigmentation. On further examination, in further history investigation, I will proceed on testosterone, as well as DHT ratio, karyotyping, HCG stimulation test, as well as gene analysis. The next part under 46XY-DSD will be a disorder of androgen action, which either is a complete, partial, or mild androgen insensitivity. The points 4 is basically hyperandrogenism, pubic hair, depending on voice, signs of realization such as schistomegaly. And further history and examination would like to ask on realization point for any complaints of acne, dramatic change in growth, and also hyperpigmentation, as well as family history of rectal injury. It's also an X-linked recessive as well. Examination point for look for any anthropometry measurements, the weight, the height, the BMI, and the skin for acne, hirsutism, as well as hyperpigmentation. On further investigation, I would like to ask on testosterone level, DHT level, LH level, karyotyping, gene analysis, as well as ultrasound and genital ureterogram to look for internal organs. Moving on under the disorder sex development will be the mixed karyotyping, will be either ovo-testicular DSD, will be either 46XX or 46XY, or mixed gonadogenesis such as 46XO or 46XY. The point 4 is basically the hyperandrogenism, presence of pubic hair, depending on voice and signs of realization such as schistomegaly. On further history and examination, I'll ask a point of view on realization, complaints of any acne, dramatic change in growth, hyperpigmentation, as well as child's menstrual history. Examination will look on anthropometry, the height, the weight, and BMI, the blood pressure and skin on acne, hirsutism, and so hyperpigmentation. The further investigation, I would like to ask on the testosterone level, FSH and LH level, karyotyping, DHES level, 17-OH progesterone level. We'll proceed with HCG simulation test, left wrist X-ray to look for any advanced bone age, ultrasound and MRI pelvis to look at the internal organs. Next, the last under the provisional diagnosis of my disorder of sex will be polycystic ovarian syndrome. The points 4 is basically hyperandrogenism, there's presence of pubic hair and depending on voice, and then signs of realization such as schistomegaly. The points against is basically in PCOS will be actually there's fat, but the child is actually weight changes of twin teen. On further history and examination on signs of realization, complaints of acne, dramatic change in growth, hyperpigmentation, as well as child's menstrual history. Look at the anthropometry measurement for weight, the height, the BMI, the blood pressure, having hypertension, and look for skin changes, calcium, acne, hirsutism, as well as acanthosis nigricans. On further investigation, we'll proceed for glucose tolerance test as they will have impact glucose tolerance test. They have high fasting lipid and FSA-LH ratio as well as DHES, as well as look for ultrasound pelvis to look for any polycystic ovary.
Thank you, Shyahlini. Based on what you said, you think is the most likely provisional diagnosis, what further information would you like to know, and what would be your next steps in management in working up this patient?
First of all, On the family history point, I would like to ask, is there any other affected family history of individuals who have any ambiguous genitalia? And then I would like to ask for any symptoms of adrenal insufficiency the child has, whether the child has headache, where the child has conscious syncopal attack, and then to look for any signs of hypoglycemia as well. And then as well as to see the child's menstrual history, whether the child has attained menarche as well. Because in my disorder, under the provisional will be the two parts, either the under-realized male or the realized female. So based on the history, probably the child is probably under the category of under-realized male.
Can I ask you, you repetitively mentioned you wanted signs of virilization and you wanted the anthropometry. Is the information given to you in the synopsis not enough for you to narrow your differential diagnosis?
The information given is actually enough.
So you have given us like a whole lecture on DSD. How do you want to narrow down your differential diagnosis?
So on my narrowing on the differential, I will go under the category of under-realized male. So we under category of 46XY DSD. So will be either 5-alpha reductase deficiency or under the category of testicular regression or testicular differentiation problems, whether it's a pure gonadal dysgenesis or ovular-testicular DSD.
So what will be your next step in assessing this child?
Next step will be proceeding with the investigation for any evidence to look for the testosterone level, the cortisol level, karyotyping most importantly to see whether the child is actually 46XY or not. And then as well as to look at the radiological point of view to look at the left rib assay to see any advanced bone age.
What do you anticipate for what you think is the most likely?
I think the child will have advanced bone age since he's actually tall. And then probably the karyotyping most likely to be under the category of 46XY. And then in terms of cortisol and also testosterone level would be actually very low for the child.
Okay. I'd like to invite Dr. Joyce to present the information that you requested.
Good morning, everybody. Good morning, Mr. Chia. Thank you for joining us.
Good morning.
Okay, so I'm going to give you a bit more information, some of the information that you've asked for, yeah, Shyahlini. So we start first with some information about the history and examination. So Anna had no complaints suggestive of adrenal insufficiency. She had no lethargy. She wasn't complaining of being tired. Going to school was just as usual. There was no absenteeism. The parents did notice an increased height velocity in the last 6 months to 1 year. There were no usage of creams either in herself or in anyone else in the family. No long-term medications. Specifically, what we're looking at would be testosterone or steroids. There was no traditional medication, some of which can contain a lot of steroids. There's no significant family history of anybody with ambiguous genitalia or suggestive of adrenal insufficiency, and she has not yet attained menarche. So her blood pressure was normal in all visits. All the readings were normal. Her height is at almost the 75th centile, while the mid-parental height was at the 50th centile. Her weight was at the 50th centile, making her BMI between the 25th and 50th centile. She had no acne. She was not hirsute. There was no hyperpigmentation, no striae, and no acanthosis nigricans.
Just before that, based on the further information that has been provided to you, can you narrow down the differential diagnosis further? I'll just go to that.
Will be going under the category of 46XY DSD, will be under the category of probably pure gonadal dysgenesis. Since she has not attained a menarche, there's no family history of any adrenal insufficiency or ambiguous genitalia. As well as she's actually tall for a family with a high velocity of 70 centile, as there's no normal BMI with the BMI within 25 to 50 centile. So I will go under the category of 46XY DSD or probably pure gonadal dysgenesis.
What do you make of the recent height and weight?
Because the mid-parental height is actually at 50th centile, hers is beyond the 50th centile at 70th centile, so she's actually tall for her age.
What about the growth spurt with relation to her age?
There's
and
sudden growth
study
spurt.
findings? Yes.
There's sudden growth spurt in her. There's increase in height velocity for her as well.
What does that indicate?
There is probably she would probably has advanced bone age. There's fusion of her bones.
Hormonally, what does it mean?
Was that suggest to you for what might be the underlying cause?
Clinical.
Or from the point of view of hormones, why that is a finding that we see? Okay, all right. Maybe we go on to the investigations and see what that illuminates.
All right, so some of the investigations that you have asked for. So renal profile is normal. Karyotype is 46XY. 17 OHP is less than 10. The LH and FSH results are such. LH is 25, FSH is 94. Testosterone is 6.7.
Can you interpret these and tell us what you think is the most likely diagnosis that you're thinking about?
Based on the investigation point, she doesn't have any warmer at the adrenals, so her renal profile is actually normal. So she's actually 46XY, so she's under the 46XY DSD category. 70 OHP is less than 10, which is actually normal. LH and FSH level is significantly high. Estradiol level is actually high, but testosterone level is actually low. So probably she have ovarian testicular disorder under the category of lack of testosterone secretion under the 46XY DSD.
Okay, so we see the biological genetics, but the hormones are suggesting something else, right? Dr. Joyce?
Okay, so those are the basic investigations. We went on a little bit further to do a HCG stimulation test. Perhaps you want to comment a little bit about what the testosterone levels are?
So on the HCG stimulation level, after the injection, there is rise, but there's no significant rise of testosterone level. Androstenedione level is also raised, but not significantly raised. We noticed that her DHES level is actually low after the stimulation. In terms of DHT and also testosterone ratio point of view is actually significantly the child has testosterone deficiency, probably sertolizole involvement deficiency. Okay.
So what's the underlying pathophysiology going on here, do you think?
From another point of view, the function of the gonads. So probably she might be having dysfunction of the gonads. So I could be a possibility a Leydig cell dysfunction.
Okay, maybe Dr. Joyce can continue with the investigations.
Okay, so this one may be a little bit too much for you, but the AMH is low for a boy, okay? And the tumor markers are all low. And on imaging, so this MRI was done in another hospital. There was a visible small uterus and what was queried as ovaries or gonads. The testes were not visualized in the usual places, and there was a visible phallus.
Yeah, so what is your interpretation of this? I mean, Dr. Joyce mentioned about the possible ovaries, but the testes were not visualized. Could you offer interpretation for what they've seen on the MRI?
He has an internal genital of female. The veil
She
can-
queried whether it was ovaries. So look at it again.
more ovaries and uterus.
So she queried whether it was really ovaries. So is there anything else? Any other way it could be interpreted?
Is it androgen secreting tumors?
Whether they truly were ovaries,
yeah.
maybe? Right? I know it says there's a small
Mm.
uterus, which might make you think that this is more of a female a makeup. But Dr. Joyce did say that they queried
It is.
whether they were ovaries, but yet they didn't see testes. So it could be that it's not necessarily ovaries. So what does that make you think about possible differential diagnosis, the most likely provisional diagnosis? Is it consistent with what you were saying, an under-virilized male?
Under-virilized male, yes. Yes, under-virilized males, I would say that.
You think it's consistent with that?
Yeah.
Okay, all right. Dr. Joyce?
Okay, thank you, Shyahlini. I think you pretty much are in the correct area. Okay, so the final diagnosis for this patient is a 46XY disorder of sex development, probably a gonadal dysgenesis. So just a little bit more about our patient. She was brought up as a female because when she was delivered with a little bit of ambiguity in the genitalia, they were given reassurance and the gender assignment was decided as female. However, she is now undergoing male puberty, and that's why we see all the signs of virilization. On the imaging, she has internal female structures, but the ovaries are quite questionable. Could it be that they're just remnants of the Mullerian structures? And also, where are her gonads, which are probably intra-abdominal? So a little bit more into the interpretation of the results that we had just now. So if we remember, the FSH was very elevated. It was 95. The LH was about 25. This is what we call an exaggerated response. And the elevated FSH actually reflects poor gonadal function. This happens both in boys and girls, where a very exaggerated response of the LH and FSH reflect poor gonadal function. There was also poor testosterone response on the HCG stimulation test. So although there was a rise, it wasn't a very, very satisfying one. We know that the gonads are producing some testosterone, but they're not producing a normal amount of testosterone for a pubertal boy. And the low AMH, which of this patient was 10, if we take it at the biological level of a karyotype of 46XY, she should be having AMH of more than 30 if there were normal functioning testicular tissue. So the low AMH suggests poor testicular function, and we can go on further to say that this poor testicular function had already happened in utero because there are persistent Mullerian structures. So AMH, anti-Mullerian hormones, are supposed to regress the Mullerian structures. Because these patients still had Mullerian structures, we can hypothesize that the low AMH already happened in utero. Further on, the testosterone and androstenedione ratio showed that it was not a 17 beta HSD, 17 beta hydroxylase deficiency, and the testosterone DHT ratio showed that it was not a 5 alpha reductase deficiency. So what's happening with her is she's currently being suppressed. So we're suppressing her puberty with GnRH analogs. She's working with our clinical psychologists with regards to gender identity because this is basically a child who has grown up as a girl her whole life, undergoing suddenly now a male puberty, and therefore it is unsurprising that she has a little bit of confusion about her gender identity. And subsequently, we would have to talk about surgical intervention for her in terms of genitoplasty and also in terms of what to do with the gonads after a decision has been made about gender identity. So just a very, very brief overview, because to talk about DSD, we will probably need the whole day, but just a very brief overview of sex development. So it used to be called intersex, then they changed the name to disorder of sex development, and lately some groups have suggested differences of sex development because they are not happy with the word disorder. So if we look at sex differentiation at the molecular and genetic level, the process is quite complicated. There are many, many genes that are involved in the process. And traditionally, we were taught that becoming a girl was a default and becoming a boy was an active process. But we now know that that is not true. There are also many genes involved in the process of becoming a girl. So you have the genital ridge, and with all these genes that are involved, finally you get either ovaries or testes. So in such a complicated process, you can imagine that if there is any disruption at all in any of these genes, we will end up with a baby with ambiguous genitalia. So when we look at genitalia, you look at internal and external. So in the internal genitalia, when there is undifferentiated urogenital tracts, you actually have Müllerian ducts and you have Wolffian ducts. So if the child becomes a boy, the Müllerian ducts actually disappear, regress, okay, and the Wolffian ducts give rise to the epididymis, the vas deferens, seminal vesicles, whereas the gonads are testes. When the child becomes a female, the Müllerian ducts persist, becoming the fallopian tubes, the uterus, the vagina, the gonads are the ovaries, and there is some remnants of Wolffian ducts left. What about externally? So externally, in an undifferentiated genitalia, you have three areas. One is the genital tubercle. The green part is genital fold. The purple part is genital swelling. So in a male, the genital tubercles will give rise to the glans penis. The genital folds will give rise to the shaft of the penis, and the genital swelling will give rise to the scrotum. Whereas in a girl, in a female, the genital tubercle will give rise to the clitoris. The genital fold will give rise to the labia minora, and the genital swelling will give rise to the labia majora. So when we talk about atypical or ambiguous genitalia, there are a few things that we need to look for: whether there are gonads in the labioscrotal folds, whether there's fusion of the labioscrotal folds, size of the phallus, and the site of the urinary meatus. Because it can be very variable, very different, we have a standard way of classifying virilization. So when we talk about ambiguous genitalia, we always talk in terms of virilization, and the degree of virilization is classified as such according to the Prader score. So you have Prader 1, Prader 2 being very mildly virilized, and then up all the way up to Prader 4, 5, which is very virilized. So on one end of the spectrum is typical female, and the other end is the typical male. So when we describe ambiguous genitalia, we use this scale. So this is just a cross-sectional view to show you what happens in the internal structures. The other scale that is used is the external masculinization score. And these are scores that are points that are given according to the criteria or according to the features that you find. Higher score is more virilized. So basic investigations karyotyping, adrenal steroids, gonadal function, imaging. These are all to help you to narrow down to what the diagnosis is. But as Dr. Shyahlini pointed out just now, usually we think in terms of whether this is a virilized female or an under-virilized male. So if it's an XX karyotype in our population, the most common cause of ambiguous genitalia in 46XX is actually 21 hydroxylase deficiency congenital adrenal hyperplasia. So we always need to rule that out. If it's XY, then it helps if we know whether there are Müllerian structures present or not. If there are Müllerian structures present, as in our patient, then we will need to look along the lines of gonadal dysgenesis. And then, of course, you have the more complex karyotypes like a 46X, 46XY mosaicism. So basically, briefly, that's an overview of ambiguous genitalia or disorders of sex differentiation.
Thank you, Dr. Joyce. I would now like to invite our panelists for their input. Mr. Chia Wee Yan is a pediatric surgeon and pediatric urologist who's joining us from Royal Hobart Hospital in Australia. Thank you so much, Mr. Chia, for sparing your time and sharing your considerable expertise.
Thank you. Yeah. Okay. Can you hear me? Is my screen sharing?
Yes, we can see your screen and we can hear you.
Oh, thank you very much. All right, thanks for the invitation. So I shall go through briefly and not talk about the things that's been talked about and concentrate on the fact that, as Joyce said, we have a 12-year-old girl with deepening voice, which suggests to me that it's either something new or which means, but if we remember, she was said to have clitoromegaly from birth. So we assume there's something from birth. And that would really mean just one thing, which is that although we have labeled her as a girl, she actually is undergoing male puberty. Rarely there's very, or some form of muted male puberty. I know that chromosomes reported 46XY, but sometimes it depends on the number of cell lines we look at actually, and if you don't see enough number of cell lines, we may not pick up some form of mosaicism. So just a thought on that we should be a bit careful on saying just 46XY with no mosaicism. The other thing is like what most surgeons want to say and always say: don't look at medical imaging reports. They can be quite not helpful as in this patient. Obviously, we actually have to look at MRI itself rather than look at the report. What the radiologist perceive as "quote unquote" a small uterus and with ovaries really mean very little, except that the fact that there is some structure in the in where we expect the Müllerian structure to be, and there are some shadows in the pelvis that the person interprets as ovary, which is more likely that that there is either a testis intra-abdominal or over testis intra-abdominal. So, and what is interpreted as "quote unquote" as a small uterus, I suspect is probably a just a hemi Müllerian structure on one half of the patient. So, yep. So, to me, it's clear. To me, the diagnosis can be only two things, really, to be honest. To me, is a mixed gonadal dysgenesis or over-testicular DSD. Yeah. And that brings me to my, I think that's been talked about before. We shall skip that. Now, although what I say now is incorrect from a genetics perspective, but really it is still for most people to remember is that, yes, I mean, unless there are male hormones intrauterine, the fetus will grow into female, or the fetus is so abnormal that it probably will not survive, or if such gross abnormalities, there's other abnormalities are obvious. If The only problem is genital ambiguity, basically, and it's normally in our other aspects, quote unquote, this kind of dictum holds to a large degree, although it's incorrect. I agree it's incorrect that the female is the default pathway. Sorry, thanks. Sorry, my phone just rang and I asked my colleague to take for me, thanks. So now, yeah, we'll skip this, yeah. Now, I have just a few things to add. Yeah. So now the thing is that, yes, sorry, I'm getting a bit interrupted. That's why. So I think that we have to understand a little bit more details in terms of the fetal sexual development. We know you need the gene to form the functioning testes, which will then therefore we say the Sertoli cell and the Leydig cells. Now we have to remember something. The Mullering inhibiting substance is an epicrine effect. That means if your testis or gonad on that side develop into testis, then it will affect the Mullering structures on that half of the patient. It will not affect on the other half. And of course, testosterone and the Wolfram structure also. And of course, the effect of testosterone is kind of universal, although we know that it has to go through a pathway for its target effect. You need a proper receptor. The receptor have to correct the enzyme function for it for final target effects of masculinization or virilization. And of course, the biggest question of all, how all this affect or not affect the brain in terms of the final gender identity is the real big question. So I have to say that the one of the more important things that so far I noticed has not been emphasized is that whether there is symmetry or asymmetry, because that has a lot of significance. Thanks, Mohan. Now, basically, if on that side of the patient some functioning testicular tissue is occurring, then that side will not have Mullering structure. But if the other side has no significant functioning testicular tissue, then that side, the Mullering structure will persist. So I think that is probably something that's generally not emphasized when we look at patients with DSC, in my view. Joyce has mentioned all that. So sorry. And the other thing is that we know that this patient has a gonad that is inside the abdomen, and we know that the chromosome is 46XY, and therefore we have to talk about the risk of malignancy. I think the risk has been worked out generally, so in general, the intra-abdominal testis has a higher risk, and of course the patient's age make it a higher risk. And although personally I disagree with the assessment that the partial androgen insensitivity have high risk, I think that's just not true, but that's for another discussion another day. So questions? We probably need some more investigations to clarify diagnosis. I mean, this child has been told a girl, and as Joyce said, yeah, the problem now is that can we be sure of a gender identity? She is definitely going through, in my view, is undergoing puberty, and can there be delay? Can we delay that safely? And how can we quantify the risk of malignancy in this child before we attempt to say what kind of surgery we can do. And depending on the society and depending on the, I mean, it doesn't apply in this case, but depending on some societies will probably accept a situation, a third gender would be a reasonable thing to think about. And so what are the, so for me, basically, I think we need to make a tissue diagnosis really. And the tissue diagnosis is for one, so basically if we do a laparoscope and have a look, then we can see, look at the gonads and personally I suspect either there's one side that's more ovary or streak on one side, and then the other side would be the other side would have a gonad that probably has functioning testicular tissue. So we need to do a laparoscope and a biopsy, one to come to a more clear diagnosis, or rather it helps us in making a diagnosis, and to quantify what's the risk of malignancy in that patient, also in that particular gonad. And obviously, Yang when we talk about, we have to evaluate her gender identity. Yeah, and I shall stop here. Basically, I mean, we can only talk about surgery once this issue has been resolved, which is, I mean, the fact of the matter is that there will be, the risk of gender dysphoria will be there either way if you decide that this child continues as a girl, or for some reason, or everybody decides that the child is better as a boy. I mean, there's a risk of gender dysphoria when the child grows up. Either way, it is at this stage is quite difficult to quantify which way is easier or better. So it's only after that question has been answered that we talk in terms of surgical reconstruction. So I mean, just some pictures that, yeah, female reconstruction, I do it this way. Basic, that means this is a reduction clitoroplasty. That's how I do it. I shall not bore you with a lot of, and reconstruct the reduce the clitoris and do the operation for the vagina. And of course, male reconstruction, then we will also have to do an operation either in one stage or two stages to create a quote unquote reasonably normal looking phallus, quote unquote. So my conclusion is that at the moment, we still not clear the diagnosis, need to assess the gonad for malignancy risk and help in the diagnosis. We certainly need time to evaluate the gender. I'm not sure whether we have enough time on that. I suspect, that's my suspicion, that we will end up eventually removing the gonad on one side in this patient, possibly both sides if the risk is high. On one side, because I think we'll see. Obviously, this is after the diagnosis, after we have done a biopsy on both sides. And of course, on thinking back, if the evaluation, the patient have to refer earlier when there's baby, child is still a baby, we might have a different outcome. Thank you.
Thank you very much, Mr. Chia. Perhaps at this stage, if anyone has any questions for Mr. Chia? Students? In your experience, Mr. Chia, what has been the norm or the more common thing that happens with regards to gender assignment and management?
I think it's slightly different when you approach it from the fact somebody as 13 years old and clearly undergoing male puberty of some sort, or those assigned as a girl. It is, I can only say my personal prejudice is, I suspect, you see, because if you want to quote unquote stop the male process, you have to do either hormonal manipulation or gonadectomy. I suppose gonadectomy would have been reasonable because if the risk of malignancy is considered high on biopsy, I think that's reasonable. So I think in the end, the pathway forward will have to be individualized. I mean, it depends so much on the child and the parents, because I suspect we don't have that much time to wait in terms to clarify, because gender identity is something that is unclear at her age or at his age, and trying to stop the puberty is kind of, it cannot be done forever. You can maybe Joyce can talk about that, maybe 1 year, 2 years, and beyond which you can't continue the hormonal suppression. So I mean, if you said that if this child had been presented when she was 6 months or 3 months old, especially between let's say at 3 months old, when we can measure the hormonal mini puberty at birth or post, at around 3 months, I suspect if I was involved, I would think that a male, I would suggest this child would have been better as a male, but that's just not the case now.
Thank you so much, Mr. Chia. That really illuminates how complex these conditions are, and that individualized management is important. I'd finally like to invite our resident clinical child psychologist to share on the psychological aspects of this case. Dr. Young.
Okay, thank you, Prof. Norazlin. We're just going to put the slides up. So first of all, thank you so much for including me in this grand CPC. And hi, Mr. Chia. Been always hearing your name. Good to meet you.
Hi, how are you?
Yes. Okay. So I was roped in by Dr. Joyce to work on this case. Previously, I worked on similar cases with Prof. Wu. I won't say I'm actually an expert in this area. It's just that I have some expertise that I can use to support these clients or patients. So usually when I get a referral, the main questions are always, the question would be like, so is it a boy or a girl? Just like how when giving birth, ONG, we actually have that question, kids will have a question. I also get that question, but not because of delivery. It's more like in terms of the identification by the young person. Okay, so we'll try to get back to this at the end of the presentation. Some of you might actually start to think about this issue, the rainbow issues. Yep. And I would also be touching a little bit on this and the importance of us to actually be aware of issues related to this. Okay, just a short summary of the case. So this young person was actually referred to me at the point when the diagnosis has already been given, and she is on this 3-monthly injection for pubertal suppression. And the referral was for psychological management. The word psychological management is a big word, because what part of the psychology are we managing and what is the focus here? So in order to do this successfully, I need to work hand in hand with the physician, in this case, Dr. Joyce. Although we do not have a combined clinic, a lot of the consultation is arranged in the sense that it's actually combined. So we have joint session together with the family and sometimes just with the child. And this is why it is actually a complex case in terms of managing the young person as well as the family. As you can see, due to logistic reasons, we've only been able to meet the family for 6 sessions. And there's also different kind of constellation of whether it's child with both parents, child with a father, or child with the mother. Sometimes what happens is life goes on. Families have their own challenges. There's a young a baby in the family at the moment. So that also affected how often mom can come along. So initially, there's always the intro and rapport that we actually have to establish, because that's how we get the trust. It is a sensitive issue to talk to a young person. So without rapport, a lot of times we would not get the full picture or information that is 100% or even true as they choose not to share. So it is important for us to establish rapport in order to actually ensure that the information sharing is there. To do that successfully, I would come in to explain my role and what is the function or what we can do. I will ensure that I do not overpromise what can be done, and they know my limitation. Parents always respect or enjoy that frankness or honesty, because then they can come and disclose things that they have done or not done. So for example, this family actually have gone to a few specialists, different clinics to sort second opinions. And we would not have found that out if they did not share that information, because our medical care is not integrated. We did not know that they would have presented elsewhere as well. So that's actually very important. Therefore, you can see the issue of gender identity was not approached until a bit later, when we have actually addressed or what is their aim or goal in the management. They disclose some bad experiences with other services, which needs to be managed to ensure that they can expect something different from us. With the child, in terms of information gathering, besides interview, I also use both drawing and also questionnaire. It is important to understand that sometimes certain sensitive issues is hard to be expressed verbally for the child to tell you directly. They may not. So in order to actually provide different avenues, there were actually questionnaires that were given, in this case, the child behavioral checklist. Interestingly, in that checklist, there's actually one specific item that says that I wish I am of the opposite sex. For that item, this child have actually marked very true. Because we are not confronting the child, I would not make that the major point of our discussion. But as a whole, the questionnaire was discussed. We found that this child actually likes to worry about a lot of things, because she described herself as a thinker. I think about the world, I think about myself, I think about many things, even things that doesn't need my thinking. So that tells me that this person would actually consider a lot of information. And I want to understand as well, how much information does this person already have right now? And I found out that this person has already started exploring the word transgender. It was not introduced by our clinic, and I was wondering where she got this. So she happily shared with me about her internet journey. And I think it's important for us nowadays, when we work with young person, to acknowledge the role of media, the internet. Even if the physicians or the parents have not disclosed or shared certain information, the young person would actually find information on their own. The danger of that is when they actually find information that is not relevant to their situation. So with rapport and with trust, this person was able to share with me and show me all the information that she's been partaking and trying to get some feedback from me. There are times where she did not need my input at all, which is okay. So my role here is also to work with her to see what she wants to focus on, and also how is her relationship with the medical team. We have questions, and we collected the questions to actually bring it to Dr. Joyce. So by the 5th session, when I actually have started introducing the topic around gender identity, we found that she did not really want to discuss about it, because she had already formed her opinion, but she did not want to tell me. She has more concern about why do I have to go for the surgery? That was her main focus. Is it necessary? Must I do it? So these are important questions. And psychologically, we would empower the child to actually have these questions, ask them, and discuss with the physician. And I'm glad I have Dr. Joyce to work with, because she is also very clued on to the young person, and she would actually share those information or discuss and share, inform when we are unaware or we do not have the answers. So psychological support is ideally provided by people who are actually experienced in DSD. The reason is partly due to the trauma that can be introduced And once a child have lost the faith or trust in the medical system or personnel, it's very difficult to engage them. So we do provide support throughout the medical or surgical discussions and interventions. So in terms of the gender identity assessments of the young person, and as well later transition to the adult services. It's important to understand what is the information that has been given and what is this person's understanding. And oftentimes it's not just the young person, but also the family. We do actually live in a multicultural society. So it's fair enough to say that we do not have enough people to work in this area and who can support in a culturally sensitive manner. At the same time, the psychosocial and educational problem that can emerge because this person still have a life to live, and school-age children, adolescents, schooling is a big chunk of the problem. So this child have already considered issues such as what would the others think about me? What does this mean, not to myself, but to my family, to my friends? So these are actually questions that I would actually discuss and elaborate, and there's no definite answer. It's not about yes or no, not about right or wrong, but what can we actually understand? What have you thought about it and how you feel about this? So the importance of the psychological input is because this is a young person who is still developing their identity. Some kids have actually very strong sense of self due to the experience that they have, due to the maturity, and therefore they might actually come in with a very forthright, open idea about how they feel or what they want. Some people, in this case, our young person here, is still exploring and trying to find their voice. Therefore, our support is actually to help them find that voice and then to see where is it that the medical team can play a role, and then psychologically, where can we actually help them so that the acceptance and adjustment is smooth. A lot of times we come to decision-making by considering what is available at that time. For psychological issue, for persons born with DSD, I think both the presenter earlier, Mr. Chia, Dr. Joyce talked about how management will be different at a young age during prenatal and neonatal and infancy. Right now, we are looking at childhood and adolescence because our client is at this path or journey, a crossroad between childhood innocence and adolescence. So some of the behavior is actually very childish, which the parents complain about, but there are also adolescence issues that they are actually struggling with. So it's important to consider all this, and we include the family because a lot of time it is the family's attitude and function that would actually impact or affect the decisions made. So therefore, I would work with the family as well. And sometimes it's about education, what is actually normal behavior, what are actually adolescents' behavior, and what are actually problematic behavior, or of course, mental health-wise, if this person actually have any underlying psychopathology that they develop due to their sense of self or that difference or bad experience that they have had growing up in a different body or in a different orientation. So to optimally counsel, we always have to take into consideration how much can the parents understand. Sometimes we say decision-making is for the parents, decision-making is for the child. But we must first identify, can they actually understand to what extent and how can they manage the uncertainty? Because sometimes even decisions can be reviewed, plans change. Can these parents deal with it? Because if they're emotionally unable to deal with it, chances are they might actually make decisions that might not be the best for the child, but it just reduces their anxiety. So it's not a decision for the best outcome, but a decision to reduce anxiety. So of course, family and cultural factors would be taken into account because how do people interpret intersex? I think that's going to be a big lecture. We're going to skip that, but it's something that we are aware of and we are very mindful. So coming to talk about this, I think a lot of times when we talk about intersex, some families or parents, the first thing that they think about maybe gays, lesbians, some of the words that they associate with sex differences. which can be very misleading. So in this case, it's important for us to actually check with the parents and also the child. What's their understanding? What have they heard? And what do they think about it? So if you notice lately, what have been happening is there's more talk about sexual or gender development, and therefore the role of what different problems or role play. So you see it's not just LGBTQ, it's growing to LGBTQIA+++. So there's a lot of things because now people are getting more aware of that situation. Therefore, if you look at this child, the child will fall in I for the old definition as intersex. What I use with this client is this concept called gender-braid person to talk about the differences between gender identity, attraction, sex, and expression, which is a simplified way of demonstrating or presenting that complex issue, because even adults struggle with this. Therefore, it's important to use something that is actually very straightforward. So there's always this idea about how much do you feel that or identify as a woman or as a man? And that's different between if you choose to be wearing something that is boyish or tomboyish, or doing something that was a gender role behavior. For example, traditionally cooking is done by women. The man does something else. It's totally different now. Does that mean that you have changed your gender? And also, of course, in her case, the anatomical sex, which she's still trying to understand. Yeah. So having these differences explained to her, not at one time, but few times, and every time with different information, additional information, and different perspective to actually strengthen that identity or sense of self. So information sharing or management is big here. There are two areas which the psychologists work with. One is actually between clinicians, parents, and child to actually help reduce the complexity of understanding for both the child and the family. Here, the communication is important, and is also why we have actually brought this to the Grand CPC, because we do actually still try to work very hard with getting the information and what is the understanding from the experts around us. And it is something that we work hand in hand with the family. But at the same time, of course, we still have to work with the child and the family about the implication outside of the clinic when they go back to their house, when they go back to their life. Because which one is more difficult or more challenging? Living a normal life with secret, or living a life without secrets but facing stigmatization and rejection? So these are some of the things that I'm working with her right now. And that's why it's important that we have a multidisciplinary approach to a shared decision-making, which we don't have yet. Hopefully, in the near future, we would have something like this to also support the clinicians, because I don't think it's an easy thing for the clinicians to manage on their own. So we actually should have a team around it. So coming back to the question, is it a boy or a girl? So as a psychologist, the main thing is I'm speaking to a person with strengths and weaknesses, who have their likes and dislikes. And that's more important to me than whether this person identifies as a boy or a girl right now, because it's a decision or identity that they will come to when they are ready. That's my sharing. Thank you.
Thank you so much, Dr. Yang. That's very interesting and intriguing. Do we have any questions from the floor? Do you want to go? Hold on.
Thank you, Prof. Lin. Thank you a lot to the whole panel. I think it's been a wonderful discussion. Just want to ask a few questions. First, to Dr. Joyce. I learned a lot today. There are new things, in gender disorders and all that. And you mentioned about anti-Mullerian hormone. And that's something that is very interesting, isn't it? How does that actually be switched on to regress the the Mullerian structures? Because this child actually didn't really complete the process, right? I mean, he has got a vagina and then he's got clitoromegaly, which could be a phallus. So, what's the signal? What's the switch that caused the anti-Mullerian hormone to actually do its function to the fullest?
I think from the beginning itself, if the genetics has determined, the genetics and the enzymes have determined that this is a boy, the testicular tissue, one of the secretions is the anti-Mullerian hormone. So if it's already been determined that it's going on pathway of the boy, then the anti-Mullerian hormone is supposed to kick in. But if there is a lack of function of the testicular tissue, as in gonadal dysgenesis or over testicular DSD, there's reduced levels of anti-Mullerian hormone, then you don't have enough to regress the Mullerian structures.
So that's the fetal testis, which is probably signaling this to form, isn't it?
Yeah.
But what then caused this dysgenesis of the fetal testis?
Oh, you mean, in this
Yeah.
patient? Well, it could be like Mr. Chia says, it's over testicular. So it doesn't function either as a testis or ovary completely, or a genetic mutation has caused the dysgenesis of the testis along the way.
So the SRY gene and all that determines that you're a male sometimes can be a bit confused.
Yeah, no.
In the sense that it's not exerting its full.
But the thing is, I think because there are a lot of genes involved in the process. So SRY is just one of it. So SRY says, yeah, you're a male.
Yeah.
But if the other genes don't do their part, then you get a.
And the other genes, by that you mean, for example?
You have the WINT1, you have FOX2, you have NAR1 something, a lot.
So that's quite complex, isn't it?
Yeah, it's quite complex. Yeah.
So it's got the interplay of all these different genes and not just the sex chromosome and SRY gene.
Correct. So as Mr. Chia said just now, it would be interesting to look into the testicular the tissue level to look at the genetics there, because it could be that he actually has 46XY in the blood, but some more sexism in the tissue, gonadal tissue itself. So that's also different.
Right.
Yeah.
The second question will be, you know, the testosterone is low, but yeah, he's going through puberty. He's got some male features. And I've noticed that the DHT there is actually high, isn't it? I'm not used to looking at the levels, but it's 100 over. It looks like it's a bit high.
Still not
or
as
normal.
good as we would like.
Oh,
Yeah.
you expect it to be higher?
It's not the good response.
I see. The DHT, I mean.
Yeah.
So the features now are because of DHT and not so much of the low testosterone, right?
Yeah.
So if you got a low testosterone, then how is the DHT?
Because the testosterone should be converted, and the DHT is the one that causes the virilization.
Yeah.
So you have a low substrate, you won't have much of the outcomes.
Because I was just Googling the level for DHT because there's no normal range there, and it looks like it's appreciably normal within the normal range. So I'm wondering, how does a low testosterone actually be associated with a kind of a normal DHT?
Yeah, so there's also enzymes in between in the process of converting steroids to androgens. So again, if there's any disruption in that pathway, you will have abnormal levels.
So there are other peripheral pathways that actually contribute to the levels of DHT as well. Okay, thank you.
Any other questions?
Thanks, the panelists. Just one question. Having a very good input now, and knowing that the child, one question about is surgery required, and then she is also kind of exploring the so-called the different terminology of this transgender intersex. Should we then be a bit more receptive of allowing what nature had done, and rather than genderizing this so-called thing and allow this intersex to kind of manifest and just accepting the fact, because she in a way start to exploring that concept. And again, that brings me to the medical kind of issues. We are suppressing the so-called puberty now because of allowing this so-called process and decision. But if she kind of like exploring this context, either kind of like allowing the puberty to proceed and influence her decision will be a bit more of a natural process that we want to be discussing. Because when I was a medical officer, I remember that we now delay the surgery, and then we eventually say that we delay also the gender assignment. Should now we a bit more move forward towards, be a bit more allowing what had nature kind of decide to allow it to manifest rather than obstructing it. Thanks.
Okay, maybe we get Mr. Chia to comment on that.
Yeah, sure. I would entirely agree with your statement that let nature take its course, to be honest. Yeah, I see no better option than that, to be honest. In terms of surgery, I think that from my perspective, I think what I was a bit more keen on is not so much as surgery, it's just a laparoscope and a biopsy of gonus. One, it does help to clarify the diagnosis a little bit, perhaps not. But more importantly, to see whether there's what's the risk of malignancy. If there's a significant risk of malignancy, then we have to act on whether we need to prophylactically remove the gonad to remove or to decrease the risk of malignancy. So only from that perspective, in terms of going forward, in terms of the gender identity and any surgical intervention based on that is just at the moment is not on, to me, is not on the table. So it's really to assess the risk of malignancy, and one, two, perhaps maybe it will help a little bit to clarify the underlying diagnosis. Yeah. But yes, your statement about let nature take its course, I surely agree.
Yeah, I wish we could go down that path, but looking at where we are now in our society and our population, we are pressured to make a decision. Of course, ideally, we would let nature take its course, as you say it, but in terms of how our society is perceives this kind of problems, we probably need to make a decision. In other countries, perhaps, they now have the discussion of the third gender. You don't have to decide. But unfortunately, I don't think we are there yet. So having to bring up this child in our society, it gives us the circumstances that we are in now.
If I may add to that, so we work on that whole spectrum of sexuality with this young person. At the same time, we also talk about laws, about culture, about family, about values, to actually show this young person that, sometimes the medical professional is giving you this advice based on what they think is a harm to the body, the risk to the self. Yeah, so for you to actually get this input, but at the same time, you can actually have other thoughts. So because she is a thinker, which works well for her, that she is given that information, that complexity. And I think that's why we would introduce the idea about what is the rules, the law, the politics, cultures, and also religion, whether it matters or not matters. So it's about that discussion that we have with this young person. And we actually have worksheets that we were using, which she is with her, so I didn't get to scan. We had, for example, a male on one side and female on one side, and it's actually like what you call spectrum. Yeah, most of her answers are actually in the middle. She doesn't strongly identify with the maleness or the male side in that, as well as for the female role and female identity. So she is like, why do we have to choose? That's all her questions. Yeah.
Thank you, Dr. Yang. Is there any other question? Hold on.
Sorry, just follow up on that. Yeah, I think we haven't really dealt much about the functionality yet and how she identifies. I think we are giving her time, right? From what Yang you're saying, she's still genderless in a sense. She doesn't identify herself yet as a male or female. Is that what you're trying to say? She hasn't really committed to where or who she is. No, yeah.
Literature, the worldwide trend right now, and also literature and research going on to like this other, as in like I'm neither male or female. Yeah, no strong identification. Yeah, but then she knows that I need to choose because I need to choose which toilet I'm going into. That is something that she is practical. Yeah, so she's explored like if I happen to move on to the surgery and be assigned male, what would happen? Yeah, because I can't pee like other people. Yeah. So that what would that? So we do with scenarios, like what could it be? Because that would actually tells you whether she thinks that is that a big problem? Is that not? Oh, is it why people worry? I don't worry about that. Yeah. So we do with scenarios and mock-ups of possible challenges for her. But is it necessary that she must identify either way? Is the question. We actually have three categories in some of our forms nowadays, which is male, female, others.
Yeah, well, that's a good point. Others and or indeterminate, I suppose, you know. So is this going, you think this is going to be permanent, or you think it's still evolving phase, I suppose? And if it's evolving, it's more likely, I see, that's what we are hoping for. It's evolving. I think that's more natural, isn't it? Rather than a permanent in terms of not going anywhere. And how much time if you were to give for that so-called decision making, because Joyce rightly pointed out that in our society, you do need to choose at this present moment. And we haven't talked about the parental aspects as well. Now, how much that's going to be important or not important at all in deciding where her gender assignment is going to be.
Yeah, I think we can agree that it's quite a complex issue. Are there any other questions or comments? No, okay. Firstly, I'd like to thank Mr. Chia for joining us today, all the way from Australia. We're really grateful.
Thank
We'll
you.
send you a picture of the food. Thanks again, Mr. Chia. I hope everyone has found today's Grand CPC to be interesting, and we can see how DST is a complex condition that's best managed in a multidisciplinary manner. And as a take-home message, we should now be aware that sex is not merely biological, but it's a more multifaceted construct, and probably still evolving over time. We ourselves are trying to understand it. You know, we might not have a full understanding even now. So please remember to manage these cases with sensitivity and compassion. And with that, I'd like to thank everyone for their attendance today. Medical students, please stay behind for some quiz questions that have been prepared related to today's CPC. For everyone else, I believe there is some refreshments. I'd like to thank you again and have a wonderful day.
Okey, kita main sorry. Okey, semua dah join Dah. Okey, kita kira 3. 1, 3.